We propose the implementation of a Mommy and Me support group to combat postpartum depression in Kalaburagi, India. Our team consists of Kaylee Gregory, Kaitlyn Stamp, and Rita Barclay-Hart. 26% of women in southern India experience postpartum depression, but 92.5% of these women cannot access care due to the strong stigma associated with mental health. 57% of people living in southern India believe postpartum depression, also known as PPD, is caused by ghost possession, sin, or black magic. Cultural factors such as the preference for male children, having more than one female child, and lack of support from family and in-laws can all affect a mother's mental health and ability to seek care. Families believe that women with PPD cannot make decisions, cannot be good mothers, and cannot take care of their children. Family members feel shame and do not tell others if someone in their family is diagnosed with PPD, find it oppressive to take care of women with PPD, and agree that if a woman develops PPD, she needs to be separated from her baby. One study discussed the implementation of a therapy group that focused on treatment for PPD in southern India, where 91% of participants felt that the group was helpful and expressed high levels of satisfaction. Additionally, the rate of depression seen amongst the women dropped by 30%. Another study showed that women who received therapy in a social setting as compared to standard postpartum care were less likely to remain depressed after 1 year.
Postpartum depression also has effects on both the children and the mothers when a mother is struggling with PPD. So the effect on children can be an increased mortality rate, especially when those children are about 6 months to a year old, more cognitive development struggles, and worse social skills as that child grows up. Now, there is more known about the effects on the children than there is the effects on the mother. But mothers are more likely to face financial issues, more likely to self-harm, and more likely to have worsened marital relationships than mothers who do not face postpartum depression. Meet Megha and Radhika, both women in India that struggled after the birth of their children with postpartum depression. Megha, having noticed the symptoms of postpartum depression, turned to WhatsApp and wrote about how she was feeling on a mommy group. She finally felt okay when someone said that they felt the same way. Another woman, Radhika, went through a similar experience and stated that only women can help other women. We need to talk to one another about motherhood and mental health as part of the whole pregnancy experience. If nothing else, it will help others identify their struggles, feel less alone, and reach out for help instead of feeling as if they are failing as moms. What helped both of these women was reaching out and talking about their experiences with other women. Our intervention is implementing a Mommy and Me style workshop. Now, this workshop will be led by local community health workers and will target young mothers who are at risk or experiencing PPD. Now, it will include the children, and mothers will be split into groups and partake in activities such as how to breastfeed and discussions that involve all of the feelings that come with motherhood and postpartum depression. There will be screening before and after the workshop of participants to see if the workshop is successful in helping with postpartum depression, and there will be a small fee to attend the workshop. But there will also be a monetary incentive where if a woman stays with the group for 8 months, she has an opportunity to become a teacher of a new group. Other group therapy interventions have had great success in India, with over 90% of participants feeling that it was a helpful experience. We hope that our intervention can have similar impact and provide a safe space for mothers to vent and explore all the emotions they are feeling and all of the experiences of motherhood, and connect them with any resources they might need to tackle postpartum depression.
Our main form of funding stems from a 3-year funded grant called the Leverage Data to Promote Equitable and Inclusive Systems of Care, which consists of $250,000 a year and then totals of $750,000 over the 3 years. This is to promote equitable and inclusive systems of care. This is done through the AWS and the few main goals they have on their site is to increase access to high quality, culturally responsive health services and to promote resilient communities by increasing access to responsive social and community support. We believe that our intervention focuses on these two main points that the AWS has on their website. Moving forward, I'm going to discuss the breakdown of our budget for year one. Year two and year three are not included, but they follow the same format, with only a difference in the senior personnel and other personnel, which they just receive a small raise over the next 2 years. So our breakdown consists of a majority of our money going to our consultants. Our consultants include 5 midwives that are hired locally within the district that we are in, one PM, 3 grandmothers that will work as babysitters for the older children that come to our program, and then a psychology expert. Another part of our budget goes to the equipment, and our equipment includes the funds for our space over the year, which is just the building. Next, our senior personnel includes one PI, and our other personnel includes 4 undergraduate students in the psychology department, preferably all female, as females travel for free on the bus in Kalaburagi itself. Finally, the rest of our budget is for our travel and supplies, and this includes flights to and from India, hotels, and then supplies consist of stuff for our intervention, such as breast pumps, items to clean the breast pumps, Legos, and toys for children, both young and old. This breaks down to yearly for our first year, $238,612. Next, I will be talking about our current breakdown overall for the 3 years. So for the 3 years, our consultants will tally up about $300,000, the equipment to $50,000, senior personnel to about $100,000, other personnel to $111,000, and travel and supplies is around $30,000. For the 3 years, this will round up to $590,954. We are a little under our budget of $750,000 for our full 3-year grant. Next, I want to get into some impact and sustainability. How does our intervention meet these two requirements? Well, first, it creates a safe space for women to bond with their children and discuss motherhood in a group setting. We also have optional screening within our group for postpartum depression, and we hope that this will increase screening rates that were previously low in India, as well as lower postpartum depression because women are getting treatment for knowing that they are diagnosed with postpartum depression. Next, there's an opportunity for revenue generation for financial sustainability. This comes from over 8 months, women then have the opportunity to become a teacher within our program. The teachers will receive a salary, and this allows women to have some control over finances in their life. Next, we have opportunities for leadership among the women, which we hope this helps them gain some control over their life and a sense of freedom as well. So, in conclusion, postpartum depression is a mental disease experienced by mothers who often do not reach out for help due to stigma, fear of their in laws' opinions, and lack of treatment options. The effects of postpartum depression do not only affect mothers, but their children as well, which often leads to a vicious cyclic generational curse that cannot be broken. Additionally, more interventions are needed to help these women before they harm themselves or their children. Thank you for attending our presentation.